You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 9th, 2024. Our topic is Insect Allergy Update. This is presented by Dr. David Golden. He is an Associate Professor of Medicine in the Division of Allergy Immunology at Johns Hopkins University. He is also a member of the Joint Task Force on Practice Parameters for Allergy.
Today we're going to talk about insect allergy. The last update on insect sting allergy was published in January 2017, actually. We're just beginning work on another update, which I hope will be published before the end of 2026, making it 10 years in between. A little long, but there are some new developments. So although I'm going to talk about almost everything listed here that is in that 2016 update, I'm going to update actually the ACE inhibitors here should say 2023 update, and likewise some of the other things we'll talk about, epinephrine, which are updated. I guess my point is in the 2024 published, but it's labeled as the 2023 anaphylaxis practice parameter update, which actually covered a lot of material that might have otherwise been in an insect allergy practice parameter. And I'm sorry, I should have had it in presentation mode there. So here you see the allergyparameters.org reference. And the only thing on this list I'm not going to really talk about is the technique and interpretation of doing intradermal skin tests. I think that's arguably a lost art. I suggest that every fellow really needs to get not only familiar with, but expert in performing and interpreting intradermal skin tests. For those of my colleagues in the past who have said it's a dangerous technique, that's nonsense. If it was, we wouldn't be using it for our most dangerous allergies, like insect anaphylaxis and penicillin allergy. But it is done differently and interpreted differently than a prick puncture test. So I'll leave it at that. But that's discussed extensively in this practice parameter. So to start off with, let's look at 3 of my patients. Posing the question, what tests and or treatment would you recommend? The answers will be on the last slide. Today, a 34-year-old woman was stung last year and within 15 minutes developed generalized hives, swelling of the face and eyes, no other signs or symptoms. The reaction subsided after a couple of hours after taking Benadryl. Does she require venom immunotherapy? Okay. Second patient, 47-year-old man had a sting on the arm. Within minutes, he felt weak and passed out. No hives, no other symptoms of any kind. He actually woke up and went home and never told his doctor until the 2nd or 3rd episode. But what diagnosis should you suspect given this scenario? And the third patient, a 52-year-old man, had a history of sting anaphylaxis and has been on maintenance immunotherapy for a year. He has diabetes and coronary artery disease, and at a follow-up visit tells you that he was recently started on lisinopril and metoprolol, ACE inhibitor and beta blocker. What do you suggest should be done now regarding his new medications? Important questions that we've addressed, and actually that last one I would have to refer you, and I will, to the 2023 anaphylaxis practice parameter update. So this is all about stinging insects. Not biting insects. Biting insects almost never cause anaphylaxis. Allergies, yes, people can get allergic local reactions to mosquito bites, for example, and others, but anaphylaxis very rarely. The stinging insects are all in the order Hymenoptera, 3 major families, the bees, vespids, and ants. The bees, mainly honeybee, and that's what we deal with, but bumblebees can sting and cause anaphylaxis. We've seen that as an occupational allergy in greenhouse workers, for example. But in case I forget to say so later, bumblebee venom is not available for skin testing and treatment. There is a serum IgE test for bumblebee IgE, but there's nothing available for treatment, and the cross-reactivity with honeybee is very limited. So honeybee immunotherapy would not be expected to protect adequately against bumblebee anaphylaxis. The ants, to go to the bottom, in this country mainly imported fire ants, genus Solenopsis, although there are other stinging ants in the U.S. The southeastern third of this country is infested, and extending out to the central and southwest to some extent too. But they actually, in recent years, have infested Australia and Europe as well. So it's really becoming a global hazard. There are other genera of stinging ants in other areas of the world, notably the jack jumper ants in Australia, for which there is a venom immunotherapy, actually. But none of those genera cross-react with fire ants. So if someone's allergic to fire ant and goes to Australia, are they going to have anything to worry about with jack jumper ants? No, at least not initially. If they get stung, they may get sensitized and have a whole new allergy, but that's not anything to do with their fire ant allergy. The vespids include the yellow jackets and hornets, and they're very, very closely related to the point where any single one of those venoms would be expected to be adequate for testing and treatment. Polistes wasps are vespids, but they're not as closely related to the group as all those others, yellow jackets and hornets, but 50% cross-reactivity allergenically. So that's why you see the dashed line to show that they're somewhat separate, but still within that vespid group. I don't need to tell you really about the signs and symptoms of anaphylaxis. The point here from data at our Hopkins group from back in the 70s, actually, when the pediatricians, Ken Schubert with Marty Valentine, were recruiting children for studies of venom immunotherapy. They noticed that of all the children referred for systemic reactions, 60% had only ever had generalized hives. So that's a cutaneous systemic reaction. It's technically not anaphylaxis, right? It's skin only, but it is a systemic generalized reaction. And let me tell you, parents can be very impressed when their child is covered in hives and their face is swollen, and the ER doctor says you're going to die next time, and then they come to me and I say, oh, that was cutaneous systemic. Oh, don't worry, that's nothing. You'll be fine. We'll come back to that point later. But cutaneous systemic reactions are very uncommon in adults. 15% in our population at the time. You see the airway symptoms being about equal, 50% in kids and adults, but the cardiovascular symptoms are predominantly adult. Dizziness, hypotension, loss of consciousness are fairly prominent in insect sting anaphylaxis, in large part, as we'll come back to, because of underlying mast cell disorders. But children uncommonly have those manifestations. This was a big deal at the time because if 60% of these children only ever had hives, the question arose, do they really need venom immunotherapy? Are they going to get worse? Important question. We'll come back to that. So then we get into diagnostic evaluation. The patient comes to you with a history of allergic reaction to a sting. What do? Well, you take a really good history first because the patient and you can be fooled by the patient's perception of the reaction, and sometimes symptoms that were subjective but maybe not clearly anaphylactic. Was it anxiety? So these things do arise. And we'll categorize as mild the cutaneous systemic reactions, moderate being some lightheadedness or throat discomfort, and severe meaning significant difficulty breathing or hypotension to the point of not being able to stand on your own 2 feet. Not always unconsciousness, but we'll call it severe if they have to sit down or lie down to prevent unconsciousness. So mild, moderate, severe. What does the history tell us? So this shows you in patients that we did sting challenge studies. We stung a couple hundred patients who had a history of systemic reaction and a positive IgE test, and therefore were eligible for venom immunotherapy, but they declined venom immunotherapy, so we were permitted to do a sting challenge. And you see that the more severe the history, the more the chance they're going to have a systemic reaction. Now that's frequency. Severity is actually a different question. It just so happens that the more severe the history, the more chance of a severe anaphylactic reaction to a sting as well. So the history predicts frequency and severity. The interesting thing we accidentally found with this study was that the yellow jackets in the red bar, Vespula maculifrons, are the mean ones that nest underground and you run over with your lawnmower and they swarm and attack you. And it turns out that they are more potent than another species that we didn't realize we were using, Vespula germanica, which much less commonly cause systemic reactions in these patients. So what does that mean in clinic? The patient who comes in and says, yeah, I had a severe reaction 10 years ago, but you know what, I was stung 2 years ago, I'm sure it was a yellow jacket, and I didn't have a reaction. Are they okay? No, because they may go back out there next week and get stung by maybe that sting that didn't react on them was Vesicular germanica. And then when they get stung by the other ones again, they may react again. Aside from the fact that there's another reason that yellow jackets in particular and hornets may cause a reaction one time and not another time, and that's because yellow jackets, for example, are known to deliver between 2 and 20 micrograms of venom per sting. That's a tenfold difference, right? So you can see why as my patients have told me, there's a light sting and a heavy sting or a strong sting. There can be a significant difference in the potency of a sting just because the yellow jacket didn't deliver as much venom. Maybe they stung someone else a little while ago and haven't really reloaded, so to speak. So interesting reasons for the variability in sting reactions. So then we move on to diagnostic testing. Skin testing or serum IgE testing, but we have to keep some things in mind. First of all, like every allergen, asymptomatic sensitization is really common. So it turns out that 20% of you listening to me right now have a positive test for venom IgE. And if you've been stung this summer, up to 40% of you have a positive test for venom IgE, even though, hopefully, none of you have had an allergic reaction. So a positive test doesn't prove anything other than exposure. Keep that in mind. Without a history, a positive test proves nothing. Moreover, people who have had anaphylaxis and have a positive test may not react to the next sting. I've just mentioned a couple of the reasons for that. It's estimated about 50% chance, although that varies with a number of factors. And the testing, I said the history predicts severity, but the testing does not reliably. So people can have a very, very strong positive test and have little or no reaction to a sting, or they can have barely detectable IgE to venom and have near fatal anaphylaxis. So although there's a correlation, there are too many outliers to use the strength of the test as an indicator of severity of reaction. Frequency, yes. Severity, no. And that's true for skin testing and serum IgE. So testing is confirmatory, but never diagnostic by itself. I won't go into a lot of details about testing. Refer to the practice parameter for a lot more detail. I personally have never done a prick puncture test other than it's a study we did a long, long time ago that convinced us there was no value in prick puncture testing. It's way too limited in sensitivity. Intradermal testing is ridiculously safe with venoms. I won't say that for everything, but with venoms, yes, to the point, and I'm going to focus on the two items in the red boxes, that it's been shown safe to begin your skin testing at the full strength 1 microgram per mil, instead of starting at 0.01, and if it's negative, going to 0.1 and then to 1 if necessary, which you may still feel more comfortable doing, but in a needle-phobic child, let's say, it may be a real blessing to be able to do just 1 strength and limit the number of skin tests you do. Of course, you could choose to do serum IgE testing, and I'll point out that reporting is now positive at 0.1 kilounits per liter. But that was not always the case. And all of the research and all of the publications about the clinical significance and predictive value of serum IgE for venom uses the 0.35 cutoff. So what does it mean when you get a result that says yellow jacket IgE 0.17 positive? We don't know, actually. And I'll show you why I have some question about that in a minute, but we don't know. Again, you really have to correlate that very clearly with history or other factors to decide what it means to you, because the problem with going down less than 0.35 is not that you're not detecting IgE. It's IgE. It's not a false positive. But you're starting to detect more and more people with asymptomatic sensitization. So actually, the clinical significance of the test seriously declines when you get to those lower levels because of the chance of that clinically it's a false positive. So we just have to keep that in mind and put the whole picture together. Fire ant, there is no venom available. It's a whole body extract. I probably shouldn't get into that long story about what whole body extracts are all about, but this one actually has enough venom protein to be useful for testing and treatment. And in fire ant, I always do prick puncture testing first. The only systemic reaction I've ever seen to insect allergy testing was with fire ant, and it was with a 1 to 1 million weight volume intradermal test. So I always start with prick puncture testing. So which is better, skin testing or serum IgE testing? Neither is better and neither is perfect. They both have good sensitivity. They both have limited specificity, mainly because of the asymptomatic sensitization. They both can have refractory periods, and that's this thing where for a week or two, maybe after sting anaphylaxis, the test can be negative. That's a false negative, and it's been blamed on exhaustion of the mast cells, but it's not just the skin test, it's the serum IgE that can also be anergic or refractory for that week or two. Maybe that's because of consumption of the IgE. There are theories, but nevertheless, both tests are affected, can be affected that way. They both, as I've said, correlate with frequency, but not reliably with severity. And really, they're complementary. I wouldn't be surprised if we go so far in the next update as to recommend that you should always do both. Whatever you start with, any venom that's negative, you should move on to do the other test. Because there is evidence that you're going to miss stuff if you only do one kind of test. I've already commented on the fact that testing, this is skin testing, but I could show you the same graph for serum IgE testing, that the strength of the test does predict the frequency of reaction. So here you see the stronger the skin test. This is an endpoint skin test, so if they're positive at 0.01, there's a higher chance of systemic reaction to a sting, but lower sensitivity, not so much. The interesting thing was and this study was done years ago, so this was before the current Immunotherapy method, so it was a RAST actually, but that's serum IgE. There were people who were serum IgE positive and skin test negative. So what does that mean? We have to assume they're still at risk, but in this particular study, what we found is those patients had the lowest frequency of reaction. And again, I think that's because we're picking up both clinically unreactive people, because if the skin test doesn't react, in that study, when the skin test was negative, the patient almost never reacted, even if the IgE was positive. So interesting comment, but you know what? Here's something for the fellows to consider. I don't think I've ever heard of or seen published a study, a similar study with any other allergen. You could do this with food challenge, for example, and look at patients, and I'm sure there are people who are serum IgE positive and skin test negative, and determine what's the clinical significance of that with a food challenge. It's not a hard study to do. I don't think it's been reported. Please let me know if I'm wrong. What if the initial test, and traditionally that's been the skin test, is negative? The guidelines say if the test is negative, do the other test. And if that's negative, then go back and repeat the tests a couple of months later. Tests can be negative on one occasion and positive on another. They seem to sometimes fluctuate about the level of detection in some of these patients. And some of them, as I said earlier, with the lowest IgE or skin test, can be the ones with the most severe reactions sometimes. There is something new that was not available when the previous guidelines, and that's component resolved diagnosis, the use of recombinant allergens to identify patterns of sensitivity, important for food allergies, for example, and in this case, to work out cross-reactivity. Up to half of our patients are positive to yellow jacket and honeybee, but most have only ever had one reaction. So what's their real allergy, and should we worry about the other one? Well, again, the practice parameters until now have said, well, you should treat with everything that's positive, because you never know whether a future reaction may occur to either one of those venoms, even if the patient's only had one reaction so far. But those venoms do have some inherent cross-reactivity, and much of the cross-reactivity that we see is due to cross-reacting carbohydrate determinants, CCDs, that are present on the natural venoms, but not on recombinant allergens because of the way they're expressed in the lab. The carbohydrate components are not added to those proteins. So that's what makes this useful to identify in this patient, are they really allergic only to honeybee or only to yellow jacket, or maybe really to both, because that's possible. They may have been genuinely sensitized to both. And that way we can tailor the venom immunotherapy to the individual patient. Not all of these allergens are available, but I'll point out that it's the unique allergens. So in honeybee, APM 1, 3, 4, and 10 are unique to honeybee. They don't cross-react with yellow jacket, and conversely, VESP V1 and 5 are unique to yellow jacket and other vespids, including Polistes. But if the patient is sensitized to the hyaluronidases or dipeptidopeptidases, they cross-react. So that's what we're really trying to figure out, and to, again, bring it back to the clinic. These are two patients who both have positive tests to honeybee and yellow jacket. Patient 1 on component testing is positive to VESV1, that's a unique VESPid allergen, so they're allergic to yellow jacket, and positive to APM1, 2, and 10, so those are unique honeybee allergens. This patient is actually allergic to honeybee and yellow jacket and needs both for treatment. Patient 2 has the same positive test to the natural whole venoms, but on component testing is positive to VESV1 and 5, unique yellow jacket allergens. We'll ignore this grayed out thing here for a minute, but not positive to any honeybee components. This patient's allergic to only yellow jacket. Why aren't they positive to any honeybee components? Well, either because we're not testing certain components, and or because this patient could, for example, be sensitized to APM2, or let me put it this way, to VESV2, which is not available for recombinant testing. But if they are sensitized to VESV2, they may be cross-reacting with APM2, even though they're not allergic to honeybee. And that may be why they showed a positive honeybee test. So that's the utility of a component resolved diagnosis. It's available as a panel from some labs and not others so far. It's been available for about 3 years now. So ultimately, we're trying to predict not only whether they will have a reaction, but how severe will it be? Who needs treatment is what it comes down to. And if someone told you you had hives all over, but it's never going to get worse, would you still feel you need venom immunotherapy? So that's the best example of the question at hand. So these are virtually all of the published studies of what happens, the natural history, what happens to people who have had reactions, systemic reactions and positive tests and are not treated. So what happens next time they get stung? And the bottom line, literally here, is out of almost 1,200 patients, almost 50% did have a reaction and 50% didn't. That's where we get that estimate of 50% chance of a reaction if you are known allergic. But you see that the estimates varied from 30% to 65%. That's a really wide range, many possible reasons, including whether the studies included low-risk patients. And we're developing the idea that there are high-risk patients and low-risk patients. And many of these studies included more low-risk patients than others, meaning cutaneous systemic reactors, large local reactors, children. That may explain some of the lower frequencies. Nevertheless, that's an interesting range, and it gives you an idea of the variability of reaction. But this was what happens with a single sting challenge. I'm going to point out two things about this. First, let's focus on Reisman, the late Bob Reisman, published one of the largest studies, and 56%, but he broke it down into children and adults, meaning greater than 16 years old, and noted that the risk was almost twice as high in the adults as in the children. He noted, and we have also over the years, that it's not true that the allergy, that your chance of a reaction will steadily decline over the years. There was no decline in reaction rate over a 10-year period in these patients. But there was variability, as I've been saying. They reacted to one sting and not another, and then went on to react to another later on. So these were some of the interesting findings in his study. One of those studies, to go back here, the second to last, Franken and Dubois, in the Netherlands, 39% reaction rate. Yeah, but they did this. The patients who didn't react, they brought them back and did a second sting challenge, and 21% reacted. There's that variability again, right? So their reaction rate really was 39% plus 21%, which sounds more like what we would expect. I retrospectively confirmed that looking back at a study I published in 1992, and prospectively in our Sting Challenge study found the same thing, because we would bring patients back and see them again. Table from the practice parameter, risk factors for severe reaction. So previous severe reaction, makes sense, absence of urticaria and angioedema, largely because it's a marker of mast cell disease. We'll come back to that. Underlying cardiovascular disease and age may be kind of the same thing, but they both are, in some studies, independent risk factors. We'll come back to talking about the beta blockers and ACE inhibitors. Laboratory markers, not much. I've been telling you that skin tests and IgE are inconsistent markers of severity. The tryptase is an important thing we'll talk about. And These other things are really not commercially or widely available, so we'll bypass them for now, but stay tuned for basophil activation tests in the future. So starting with tryptase. 2009 was kind of a watershed year for something that had been building up for about a decade already. And 2009 was also, incidentally, the year that the serum tryptase as a lab test first became available in the US, 2009. And that was the year that this study was published in 379 patients with insect sting systemic reactions and I'm not even going to say positive tests. These were patients who had systemic reactions to stings. Of those, 11.6% had an elevated baseline serum tryptase, and elevated meaning greater than 11.4. What's really elevated is a whole other matter, but that's been traditionally and is still in most labs reported as the threshold for elevated. 11.6%. It actually, depending on the patients you're seeing, may be much higher. For example, bottom line, literally here, grade 4 reactions in this scheme means hypotension. And in the patients who had hypotension, 25%, 31 out of 124, had elevated serum tryptase. So there's a strong correlation there. But the tryptase was elevated in 5, 10, maybe even 15% of the not so severe reactors or non-hypotensive reactors. We can now look back at that and say we believe that most of that is related to hereditary alpha tryptosemia, which exists in 5 to 10% or more of these patients, but was unknown at the time in 2009. It's only described by Jonathan Lyons somewhere around 2016, I think. Other note from this study, allergy tests were negative for venom, as you see in the middle here, in 4 patients only, and all 4 of them had elevated tryptase. So when the tests are negative, make sure you check the tryptase and anything else you need to do to rule out an underlying mast cell disease, mastocytosis in particular, as the cause of the systemic reaction, even without IgE. This is the other watershed 2009 study, European Interest Group on Insect Allergy, so a large number of patients, and it showed this linear correlation, although note that the tryptase is on a geometric or log scale. Linear correlation between the tryptase and the odds of a severe reaction, such that at 11.4, the threshold of elevated, it was already more than 2-fold increased odds of severe reaction. The truth is that this curve does not go endlessly up. It's been, you notice that they only had like, what, 2 or 3 patients that were over tryptase of 30. When patients with high mast cell burden and tryptases of 50 or 100 are studied, this curve actually starts to come back down, interestingly. The patients with the highest mast cell burden do not have as much increased risk, and that's probably because of their different kinds of mastocytosis. Turns out that, and I'll tell you to read up on this in review articles and upcoming review articles, but bone marrow mastocytosis is the term for what most of these patients actually have, and they do not have, and that's bone marrow. It's hard to detect in the blood or tissues, and they do not have as high mast cell burden, and they're the ones that actually more commonly have the sting anaphylaxis, interestingly. So when should you check the tryptase? Frankly, I'll tell you that at this point, what I should be showing you, and I don't think I put it in, I'm sorry, I apologize, but you should look at the anaphylaxis practice parameter published in February 2024, because it will tell you differently that any patient with severe anaphylaxis, recurrent anaphylaxis, hypotension without urticaria, all of the above should be tested for tryptase for sure. Some of that is noted here: hypotension, absence of urticaria, severity, negative IgE. But any patient who, I'll go straight to the bottom here. We now recommend any patient who's a candidate for venom immunotherapy should have their basal serum tryptase level checked. And if it's greater than 8, not 11.4, I'll refer you to the anaphylaxis practice parameter. If they're greater than 8 and have a history of anaphylaxis, they should be investigated for mast cell disorders, including mastocytosis and hereditary alpha tryptosemia. They may even have both. We've seen that. So you can also test for the c-KIT mutation in whole blood, not just in bone marrow. And with the newer high sensitivity PCR assays, like the digital drop assay, it's much more sensitive. and can detect even a lot of those patients with what I just mentioned as bone marrow mastocytosis, but not all of them. So the interesting thing about this study, and you'll notice that almost all of them had hypotension, grade 4. There were a couple of grade 3s in here. But these are patients who had mastocytosis and had normal tryptase, even less than 8 for that matter. So, point is, if they fit the pattern of mastocytosis, and there's a scoring system, the REMA scoring system, again, look into the anaphylaxis practice parameter, but that's especially hypotension, absence of urticaria, then they should be, even if the tryptase is normal, they need to have the c-KIT mutation tested in whole blood, and if that's negative, they need a bone marrow biopsy. So there are risk factors, if you will, or a profile that makes it highly suspicious for mastocytosis, especially in males. I should have mentioned that REMA score is males with hypotension, absence of urticaria, and they include the tryptase as part of their scoring system. We look at it as an indication to check for, with or without tryptase in insect allergy, to check for underlying mast cell disease. So there's some newer studies that are going to make me update this slide to say the clonal mast cell disorders may occur in up to 20% of patients with insect sting anaphylaxis, especially if we're getting rid of the cutaneous reactors. People who have mastocytosis, 40 to 50% will have anaphylaxis during their lifetime, and insect stings are the most common cause of anaphylaxis in patients with mastocytosis. And almost every reaction in those patients is life-threatening and sometimes fatal. Hereditary alpha-tryptosemia, 5 to 6% of the general population, but 10 to 20% of patients with insect sting anaphylaxis, not cutaneous reactors, anaphylaxis. HAT is associated not with more chance of reaction, but more chance of severe reaction, and certainly elevated tryptase likewise. In patients with mastocytosis, although it was 30 years ago said that we shouldn't give them venom immunotherapy, it's too risky, we now strongly recommend it because it gives them not as good protection as everyone else, but pretty good, and greatly reduces, we hope eliminates, the risk of fatality, which is a real risk in patients with mastocytosis and insect sting anaphylaxis. And interestingly, although they have slightly higher chance of adverse reactions, it's really not that frequent, surprisingly. So now, beta blockers and ACE inhibitors. Again, I'm going to refer you beyond what we say in the insect parameter, the last one, and to the current 2024 published anaphylaxis practice parameter. The studies I'm going to show you were published only in 2021, for example. I need to put the reference on this slide. I'm sorry it's not there. So this is the first and only, so far, systematic review and meta-analysis of studies of the use of beta blockers and ACE inhibitors in relation to anaphylaxis. So their findings were basically that both were associated with increased severity, but not increased frequency or incidence of anaphylaxis. They don't make anaphylaxis more likely, but they do increase the chance it will be severe. They could not fully adjust for cardiovascular disease because there's such an intimate connection between cardiovascular disease and being on beta blockers and ACE inhibitors. But in the few studies that did look at it, the odds ratio for severe anaphylaxis was 3 times higher in relation to underlying cardiovascular disease than in relation to the beta blockers, and 5 times higher for the cardiovascular disease than for ACE inhibitors. So the real risk is the greater risk, I should say, is with the underlying cardiovascular disease. And if you have these patients change or discontinue their medication, you're probably increasing their risk overall, even for anaphylaxis, because you're increasing the risk for their cardiovascular disease. And there's a really interesting older article that did a simulation analysis of life expectancy, and their analysis showed that in patients with anaphylaxis that they'll live longer if you maintain their beta blocker despite the higher risk of severe anaphylaxis than if you stop the beta blocker or ACE inhibitor. So we are now recommending that in patients on maintenance immunotherapy, we don't need to do anything about them being on these medications. They're fine. Patients starting venom immunotherapy, there is a little bit higher chance of reaction being severe if they're going to have a reaction. But we go back here, I hope I have the time to mention the concept of absolute risk and relative risk, okay? So And the example, and I'm making up numbers here, but if someone has a 1 in a million chance of severe reaction, and if being on these drugs triples that risk, okay, so now it's 3 in a million. The relative risk has increased 300%. The absolute risk has increased 300%, but it's still incredibly low. So we have to keep that in mind when we talk about risk and increased risk, about just how low was it to begin with, or how high was it to begin with before it was increased, and does it really make a difference? This is a judgment call, and almost all of our recommendations are conditional, and that is a signal for shared decision making. It means that we have evidence to support our recommendation, but the evidence is not of the greatest quality or certainty, and there's room for discussion with patients, because sometimes patient preferences and values actually will make the difference in some of these decisions. The other study, this was the 2021 study, looked at specifically venom immunotherapy. Incidentally, this one was all causes anaphylaxis. This one is insect sting anaphylaxis. 1,400 patients, history of anaphylaxis and a positive test. Retrospectively, they were not found to have more severe reactions to stings if they were on ACE inhibitors or beta blockers. And that's surprising, because we actually believe that it is associated with a slightly higher risk, but they didn't show it. Prospectively, the ones who went on venom immunotherapy and were on ACE inhibitors or beta blockers did not have more adverse events, reactions during venom immunotherapy, and after a year on treatment, when they had a re-sting, either challenge sting or in the field, there was not a higher frequency of reaction if they were on the medications. So this particular study really showed no difference whatsoever. Even though we're still going to err on the side of caution and say, yes, there may be a slightly higher chance, if they have a reaction, that it may be severe. Not more chance of having a reaction, but if they have a reaction, it may be more severe. So the concept of low risk and high risk factors and patients comes into also the prescribing of epinephrine autoinjectors. I just want people to think about this. Compared to the rest of the world, we are gross overprescribers of epinephrine autoinjectors, because we reflexively prescribe it if there's 0.1% chance of anaphylaxis. And I'm referring to omalizumab, which has a 0.1% chance of anaphylaxis, and only in asthmatics, incidentally. And yet we're expected to prescribe an epinephrine injector. So I don't know. Sorry, it doesn't make sense to me. And I discussed that with my patients, because it doesn't always make sense to them either. And having an EpiPen is not a benign, giving that prescription is not a benign prescription. And there's evidence for that. So patients at low risk for having an insect sting reaction, and we haven't really talked about the large local reactors, but like the cutaneous systemic reactors, they're at very low risk for having a moderate to severe, or in other words, anaphylactic reaction. Patients on maintenance immunotherapy, patients who discontinued immunotherapy, maybe even if they just have an affected relative they're scared and want to have an epinephrine injector. Should you prescribe it? You should discuss it with them as to what's entailed and why they do or don't really need it, and what the real risk is of them needing it, and then let them decide if they really want it or not, frankly. But always prescribe it for the high-risk patients. No question. So I'm saying this because of another study from, I mentioned Franken and Dubois on the tryptase. Same group, Audi Elberink and Dubois, created a quality of life instrument for insect allergy, validated it, and then did a randomized study where patients were randomized to venom immunotherapy or EpiPen. And a year later, did their quality of life improve? Yes, very dramatically in venom immunotherapy, because the change of 0.5 is significant. Not only did it not improve, it got worse with the EpiPen, because those patients did not feel safe and secure. Okay, they had an EpiPen, but by the time you need an EpiPen, you're already having anaphylaxis. The patients who got venom immunotherapy felt much more secure. So, and a prescription for an EpiPen in a way is a prescription for fear. You're saying, oh, we're not worried enough to give you venom immunotherapy, but here's this EpiPen so you don't die. I'm making this stark contrast, but just trying to get people to think about the mixed message we sometimes give patients when we say, oh, you're not really at risk, but we think you should have an EpiPen. So I'm saying is think about it and maybe discuss it with the patients. Because in this study, same study, on the left is what I just showed you. On the right are the patients who declined to be randomized. They were allowed to self-choose. Venom immunotherapy, which obviously gave a dramatic improvement in quality of life, and EpiPen, which gave a slight improvement in quality of life, not a decline. Why? Because these patients wanted it. They valued it, they preferred it, and it gave them security. And these are the patients who you should prescribe it to because you're improving their quality of life, even though the risk of needing it may be very small. Venom immunotherapy is indicated in patients, in my opinion, who have significant risk for a moderate to severe reaction. You know, we looked at this before, and the real question is, who's going to have a severe reaction in the future? There was a study published, actually, maybe I'll scoot ahead to this slide. The children, Valentine et al., New England Journal, 1990, was the paper that showed that children with cutaneous systemic reactions in that study had a 0% chance of a more severe reaction. Ken Schuberth published and presented an abstract in a larger data set and found 1.1% after a 9-year observation period. These were not sting challenges, these were field stings. No data in adults, but actually in our sting challenge studies, we stung 81 adults with cutaneous systemic reactions, and only 2 had a moderate systemic reaction, more than just hives. 2 out of 81. Interesting, none of the moderate reactors became severe. So the point is that only 2 out of 259 became more severe, actually. So this gets rid of the myth that it's going to get worse every time you get stung. No, that's the exception, not the rule. Therefore, people with not that bad systemic reactions may feel that they don't want or need immunotherapy, and you know what? They may be right. So in adults, I just showed you the data that we had, and van der Linden, in the study I showed you earlier, he didn't really talk about it, but if you look at the published data, he did sting 47 adults with cutaneous systemic reactions, and none of them had a more severe reaction. So in the practice parameter published in 2017, we changed the recommendation such that adults with cutaneous systemic reactions do not require venom immunotherapy. Note the word not required for cutaneous systemic or large local reactors, because they have, we're saying less than 5%, actually we believe less than 3% chance of needing epinephrine for a future sting reaction. Now that's not zero, but before we get excited about a 3% risk, what's the population risk? It's about 1 to 1.5%. So yes, they have maybe twice the population risk, but it's still pretty low. I mean, should everyone with a positive test in the population? You know, I mentioned that a lot of people have a positive test but are asymptomatic. Yeah, but their risk is not zero. It actually is like the cutaneous systemic reactors and large local reactors. Should 20% of adults be on venom immunotherapy because they have a 3% risk? That's ultimately the question. And when I talked about testing, you know, I failed to recommend something that's really important. Please don't test anyone who is not clearly eligible for venom immunotherapy. A positive test will create fear, but a positive test doesn't create increased risk. It will not help you make a therapeutic decision. You have to decide that before you do the test. The test is only confirmatory. When does that really, really matter, besides messing up people's lives? When that person wants to go into the military. You won't believe the number of patients I know of and have seen who had a test. They had a shady history. Oh yeah, you know, my mother said I might have had a reaction when I was young. Or yeah, my arm swelled really big and someone gave me an EpiPen. They're not going to be accepted into the military because of that. And if you do a test and it's positive, their fate is sealed. Remember that 20+% of adults have a positive test and most are asymptomatic. So don't do the test unless if there's not a clear history of moderate to severe anaphylaxis from a sting, because a positive test will keep them out of the military. And you're going to need an expert letter of recommending that, as mentioned in the guidelines, that this patient really doesn't have risk and shouldn't have been tested in the first place, and shouldn't have been given an EpiPen in the first place. So it's an uphill battle from there. So I really felt I had to mention that. Large local reactions, I've mentioned them a couple of times. Delayed inflammatory reactions, they are IgE dependent. They can cause lymphangitic streaks. So this is the patient who wakes up the next morning with swelling from the wrist to the upper arm and a lymphangitic streak into the axilla and goes to the ER and says, oh my God, you have cellulitis, we're admitting you for IV antibiotics. First of all, teach that ER doctor, please, that it is impossible to get cellulitis in 24 hours from a sting. 4 or 5 days, maybe still really incredibly rare, but 24 hours, no, it's just not possible. And even if they're immune deficient, I don't think that's possible. That's an allergic lymphangitis, and the treatment is conservative, cold compresses, maybe steroids for a couple of days if the local is really big. But what's their chance of reaction? I've already alluded to the fact that we believe it's less than 3% chance of anaphylaxis, 4 to 10% chance of a systemic reaction, which is mostly just hives. There's one study, BELO 2019, that raises an interesting question. If they've had 3 or 4 large locals, they're probably going to continue to have large locals. If they've only ever had 1 large local, is there maybe a higher chance that they might progress to a systemic? She thought her data, I shouldn't say she thought, she published data to say yes, that would be true, but she herself says this really needs further study, and it does. Should they get epinephrine injectors? I've already said that's really shared decision making. They don't really require it, but they may want it, and likewise for immunotherapy. But immunotherapy does greatly reduce large local reactions. So for the beekeeper or landscaper or someone who really gets stung every year and gets large locals every year, they may warrant venom immunotherapy because it can seriously reduce by 50 to 70% in this study the peak size and duration of the large local reaction. So it is potentially indicated in some patients. Details of venom immunotherapy, just a couple of things that maybe are not obvious and are in the practice parameter. You can start treatment with 1 microgram. That's 0.1 mils of 10 microgram per mil. Rather than the package insert and the traditional regimen starting at 100,000th of that dose and gradually increasing, the package insert for the current product in this country is a so-called traditional regimen, weekly dosing starting at a very, very low dose and increasing for 4+ months. Frankly, that's ridiculous. The next statement tells you that modified rush and rush regimens, modified rush is once a week for 7 or 8 weeks, which is what we've been doing in every patient for the past 40 years. And rush is in 2 to 3 days. Those regimens are as safe or safer than the traditional regimen that's in your package insert. So rethink it. There used to be another product, some of you may not know this, by another company for 30 years in this country. They chose to stop marketing it. It's available in the rest of the world, and it carries an FDA-approved modified rush regimen that reaches. And so again, there is an FDA-approved regimen. It's in the chapter in Middleton's textbook. It should be considered, and frankly, for some patients, again, shared decision making. Does this patient would rather come once a week for 8 weeks because it's less disruptive to their schedule, or would they rather just spend 2 days in clinic and get it done? Just as safe. Some patients will take you up on the 2-day rush regimen, but you have to be able to commit your clinic to doing that. Reactions during therapy, less frequent with venom than with grass or cat, frankly. And what do? You do what you always do. You reduce the dose, you increase it again, you maybe pre-medicate. In the case of venom, you always make sure you know the baseline serum tryptase because that could be the reason. And if they have repeated systemic reactions, if they're not on a rush regimen, they need to be on a rush regimen. It actually usually works out just by doing that. And often with pre-medication. But if that fails, omalizumab, this is off-label, but there are dozens of reports of success and some of failure in using omalizumab to facilitate reaching maintenance in venom immunotherapy. This is the rush regimen, first published by the Bernsteins in Cincinnati in JACI 1994, and adopted by Goldberg et al., who has published several papers on this. In this case, these patients were having repeated systemic reactions to venom immunotherapy with a traditional regimen, and when he switched them to this regimen, they had no trouble building up to maintenance. How long or when should you stop venom immunotherapy? There used to be a lot of discussion about 5 years versus 3 years. There's no question in the literature that 5 years is better, but there could be patients, low-risk patients, who maybe chose to go on therapy, but maybe they don't really need 5 years. But that's a maybe because there's no study to clearly show that. Should you evaluate the patients? You should definitely make sure you're aware of their history. You should definitely know their baseline serum tryptase before you stop their treatment. If you didn't do it when they started, you need to do it now. If you did it when they started and it was 9 at the time, that was reported as normal, you need to repeat it. It may be 12 now. Should you skin test or do serum IG? No. It has no predictive value when it comes to stopping venom immunotherapy. In patients where we stopped immunotherapy after a mean of 6 years, they were off for a mean of 3 years, 10% reaction rate. Patients who were off for almost 10 years, 9.6, also had a 10% reaction rate. So the lesson is that the risk does not go down with time, again. And that means that if they get stung not once in that 10 years, but 2 or 3 or 4 times in that 10 years, then their risk lands up being 14 to 17%. That's the cumulative risk shown on the bottom. In this 1998 paper, it was 14.2. In the 2000 paper, the final in the series, it was almost 17%. So frequency of stings and frequency of exposure is potentially a reason not to stop treatment. And this is from the practice parameter when to consider extended treatment or indefinite treatment based on very severe reactions, elevated tryptase, systemic reaction during treatment to a sting or a shot, honeybee anaphylaxis. And I mean actual anaphylaxis to a honeybee, not just a positive test in someone who reacted to a yellow jacket. And as I mentioned, frequent exposure. There's some softer issues if they're on ACE inhibitors and beta blockers, which may increase severity if they react. Again, their risk of reaction may be very low, so should you worry about it being a little higher on the medication or not? Well, that's a judgment call. And just impaired quality of life. There are patients who, if they stop, it's going to affect their quality of life and lifestyle. And at that point, they may be able to continue every 12 weeks, 4 shots a year, which many of them will gladly choose to continue treatment just to have that ongoing protection. And lastly, about discontinuing treatment. So this is kind of a post hoc analysis that takes our data and projects it into 100 patients, 100 of our patients. Out of 100 of our patients in whom we stopped immunotherapy, 1/3 had a high risk factor and 2/3 did not. The 1/3 had the factors shown on the bottom, like the things I just mentioned: systemic reaction during treatment, elevated tryptase, near fatal reaction, frequent exposure, or honeybee anaphylaxis. If 1/3 had one or more of those 5 high risk factors, and when they stopped treatment, their reaction rate was 45%, almost what it was before treatment. The patients who had none of those 5 high risk factors, the other 2/3, when they stopped treatment, had a 3% reaction rate, not hardly more than the general population, and they were all less severe than the original reaction. So this helps you to think about which patients to stop and which patients to recommend extended treatment. So we'll go back to the patients I showed you at the beginning. The first patient had, as an adult with a cutaneous systemic reaction, no, she does not require venom immunotherapy. And please tell people not to take Benadryl. It really just confuses the issue. We're working with a group in Canada that wants to actually have it taken off the over-the-counter market. And I personally think that's a great idea. Second patient was a male with hypotension and no hives after a sting. That's mastocytosis until proven otherwise. And the third patient is on maintenance immunotherapy and gets put on a beta blocker and an ACE inhibitor. We now recommend in the 2023 anaphylaxis practice parameter that you should not change their medications. So, but things do change over time. That's why we do these updates. So I'll leave you with my latest inspiration and an email address in case you want to share a case or ask a question. I field a lot of them, and that's actually a tremendous help to me to be able to share not only my own experience, but the experience of all the allergists who have shared their experience with me. So thank you very much, and